Good evening, ladies and gentlemen. It's a great pleasure to welcome you on the second edition of the ILEP webinars, International Lipid Expert Panel webinars, which is the first part of this second edition is dedicated to nutraceuticals. So we would like to answer all your questions and doubts concerning the using on nutraceuticals, why, when, and what patients might benefit the most from nutraceuticals. The second webinar will be completely dedicated to the very specific questions and very specific situations. We would like to be much more specific in order to answer the questions whether we might consider nutraceuticals in patients at the risk, in secondary prevention, in patients at the very high risk, maybe extremely high risk, maybe in patients with statin intolerant, and especially we would like to say tell you very detailed information about the nutraceutical safety. So whether it is important or not, because it is natural products, and we know that most of nutraceuticals are very well tolerated, but we would like to give you a very clear message on what patients might benefit the most, in what patients we should consider nutraceuticals in order to be optimal with the therapy, and finally, what kind of knowledge we have and what level of knowledge we have on the nutraceutical safety. It is my great pleasure to be this evening with my great friends, and at the same time the greatest experts in the field in Europe, and I believe also in worldwide. So it is my great pleasure to welcome Professor Niki Katsiki from Greece. Niki, it is a great pleasure that you are with us. Professor Zeljko Reiner from Croatia. Zeljko, thank you very much. And top number one, I guess, in the world in the field of nutraceuticals, Professor Arrigo Cicero. I've learned a lot from Arrigo concerning the nutraceuticals, and that is why I am here. So I can moderate this evening. As this webinar. Okay, we don't want to prolong with the introduction. I don't want to prolong with the introduction because I do believe we will have time in order to have a great discussion with you. Especially we have had already the first questions on the nutraceuticals and the forthcoming presentations. And I would like to give the voice and to give the floor to Professor Zeljko Reiner, who would like to say a few words about the nutraceuticals role, potential role in patients at a high and very high cardiovascular risk. Zeljko, the floor is yours. Thank you very much.
Thank you, Maciej. As you can see from the title of my presentation, Professor Banach has probably given me the most difficult task, because when we are talking about very high and high-risk patients and nutraceuticals, probably most of you would just do something with your eyes and look very suspicious. So if we look at the last guidelines that were published last year, very high-risk patients are those who have proven cardiovascular disease, documented either as previous acute coronary syndrome, stroke, peripheral artery disease, and so on, or those patients who have diabetes with target organ damage, or at least 3 major risk factors and diabetes, or an early onset of type 1 diabetes of long duration, as well as patients with severe chronic kidney disease, or calculated score more than 10% for 10-year risk of fatal cardiovascular disease. And of course, familial hypercholesterolemic patients who have survived cardiovascular event with another major risk. As high-risk patients, we consider those patients who have significantly elevated single risk factor, particularly total cholesterol over 8, LDL cholesterol over 4.9, patients with familial hypercholesterolemia, but without other major risk factors, those with diabetes without target organ damage, but with diabetes duration more than 10 years or another additional risk, those with moderate chronic kidney disease, or calculated score more than 5%. Of course, these guidelines help us also to determine what are the goals of treatment for each cardiovascular risk category. And taken in general, the message would be, as you can see in red here, that no level of LDL cholesterol below which benefit ceases or harm occurs has been defined. And there is definitely no known adverse effects of very low LDL cholesterol levels, meaning less than 1 millimole per liter or less than 40 milligrams per deciliter. So for those patients who are at very high risk, and we have just described them, we try to reach at least the decrease of LDL cholesterol at least 50% of the baseline value, or less than 1.4 millimoles, less than 55 milligrams per deciliter. For those who are not using statin, they should be prescribed intensive LDL lower therapy, or also those who have already LDL lowering therapy and need to increase the treatment intensity to get lower LDL cholesterol. In high-risk patients, for them, the goal is, again, either to decrease the LDL cholesterol level from baseline at least for 50%, but LDL cholesterol in them should be less than 1.8 millimoles or less than 70 milligrams per deciliter. So there is a lot of evidence suggesting exactly this. And when you compare this 2019 guidelines with 2016 guidelines, you can see that the major difference is exactly here in very high risk and high risk patients. It used to be target 1.8 or 50%. Now it's less than 1.4 or 50%. And high risk, it used to be less than 2.6 or 50%. Now it's less than 1.8 or 50% decrease. It is quite clear that a lot of our patients require statins plus additional lowering therapy to achieve these LDL goals. And patients who are requiring additional treatment are typically high-risk patients who have very high LDL cholesterol levels. So those who are at very high risk and remain at high risk despite maximally tolerated statin treatment, then ezetimibe should be recommended. And this is also in the recent guidelines. We have relatively recently published, I think, all the presenters participated in this. Several years ago, general position paper about lipid-lowering nutraceuticals in clinical practice. And if you look at those nutraceuticals, you can see a lot of them. And of course, we don't have time to speak about all of them, but we'll concentrate it on some of them. And these are monocolins, berberine, and some others. What do? They target liver primarily. However, of course, we do have nutraceuticals which target intestinal cholesterol absorption. Berberine is one among them, but there are some others like bergamot, lupin, psyllium, probiotics, soy, artichoke, and so on. And there are also some of the nutraceuticals which target triglycerides, among them bergamot and omega-3 fatty acids, as we all know very well. However, I'll try to concentrate, as I said, to monocolin K, which originates from red yeast rice, and it can be in form of either lactone, which is inactive form, or hydroxyl acid, which is active form. It is depending upon pH circumstances. When it is in active form, it inhibits the crucial enzyme in synthesis of endogenous synthesis of cholesterol, HMG coenzyme A reductase, and it is structurally identical to lovastatin. So when we are talking about monocolin K, we are in fact talking about lovastatin, usually only in much smaller doses than lovastatin is applied. There are several studies which studied and compared monocolin K with some other substances, with statins. For instance, I will just quote one of them with the low dosage of monocolin K, which achieved a reduction of LDL cholesterol. It was a randomized placebo-controlled trial showing clearly this reduction. A meta-analysis of red yeast rice, including monocolin K as a major substance, on total cholesterol showed a clinically relevant hypercholesterolemic effect. Up to 20% reduction of total cholesterol can be shown with red yeast preparations, providing a daily dose between 2.5 and 10 milligrams of monocolin K. Late, about the same time, a meta-analysis was performed based on 20 studies on the effects of red rice on LDL cholesterol, showing again that it really does decrease LDL cholesterol significantly. Red yeast rice combined with coenzyme Q10 has been shown several years ago to improve lipid pattern, endothelial reactivity, and arterial stiffness, and therefore has obviously pleiotropic effect and not only lipid-lowering effects. Also, the combination of monocolin K, L-arginine, and coenzyme Q10 and ascorbic acid had also significant lipid-lowering effect concerning total and LDL cholesterol, and increasing HDL cholesterol and decreasing triglycerides. The effects of combined treatment with monocolin K, policosanol, berberine, folic acid, astaxanthin, and coenzyme Q. So you can see nutraceuticals, which are lipid-lowering, as well as those which are antioxidant, showed a significant effect on lowering total and LDL cholesterol, and lowering total cholesterol was between 11 and 21%, and LDL cholesterol between 15 and 31%, which is actually equivalent to expectations from low-dose statins. An important study was made was published 3 years ago, showing that after 3 months, patients on low-dose statin plus armolipid plus, which is actually the combination that I have just presented to you, had a significantly great reduction of LDL cholesterol and total cholesterol, and about 70% of patients in this group achieved the therapeutic target of LDL cholesterol less than 70 milligrams per deciliter or less than 1.8 millimole per liter. So this combination plus low-dose statin, and I'm stressing low-dose statin, obviously can achieve even the goals that are given by the recent guidelines. So if we would like to summarize all these findings, we can say that nutraceuticals, at least those which I have been discussed in more detail, decrease LDL cholesterol, particularly monocolin, either alone or in combination with some other nutraceuticals, without significant adverse effect. Of course, Professor Katsiki will talk about the adverse effects much more. It has to be emphasized that high-quality nutraceuticals, including combinations of nutraceuticals, cannot replace intensive lipid-lowering therapy, which is usually needed in high and very high-risk cardiovascular disease patients, but it might help to optimize it, as we could see from the last study showing that even the optimal goals concerning LDL cholesterol could be achieved when using these substances. However, we have to say quite openly, hard data are still lacking to prove that nutraceuticals, including monocolin K alone or in combinations, which I have mentioned to you, can prevent cardiovascular disease or can prevent cardiovascular events or even cardiovascular disease mortality. Thank you very much.
Thank you very much, Zeljko, for a beautiful presentation. I believe it was indeed a hard topic in order to answer the questions whether nutraceuticals might be useful in very high risk and high risk patients. And I believe at the end of this meeting, during the discussion, we will discuss what to do in those patients being at a very high risk, without possibility of treating, for example, with PCSK9 inhibitors out of the target, and whether adding of the nutraceuticals to statins and ezetimibe might be an option for them in order to be on target, because it is probably one of the questions we would like to answer to our people that are with us and participants of the meeting. So, but we will leave it to move it to the discussion. And if you don't mind, I will move with my presentation on the possible application of the nutraceuticals in statin intolerant patients. And when I would like to say a few words about the forthcoming International Lipid Expert Panel recommendation on statin intolerant, which I have been working very hard in order to be released by the end of the year. It will be very practical approach to statin intolerant patients, including also new drugs such as bempedoic acid, such as PCSK9 inhibitors, inclisiran, as well as obviously nutraceuticals and their role in statin intolerant patients. We know it very well, and we discussed it during the first webinar, that we need to be as early as possible. It is not only important to be as low as possible, for longer, so the longer the better, but we need to be also the earlier the better. But on the other hand, if we know that we do not have an option of using statins, and we do not have the effect of the reduction of the LDL cholesterol with statins in patients with statin intolerance, the question is that, and there is no question that it will be increase of the risk of the cardiovascular events due to the high levels of LDL cholesterol. So in this situation, we need to have a very concrete tools and very concrete management, how to manage with those patients with statin intolerance in order to still reduce LDL cholesterol and in the end reduce cardiovascular risk, taking into account the longer the better, the lower the better, the earlier the better. Do we have a data that not adherence and statin intolerance is associated with the increase of cardiovascular events? Yes, we have. It is one of our papers published in 2017 by the group of, I was also involved, but it was especially the group of Professor Paul Mantner and Professor Robert Rosenson with ILEP member Dr. Maria Corina Serban. And as you can see, we've noticed it was based on the Medicare data that if we are not adherent in comparison to those with very good adherence to statin therapy, it is associated with the increase of recurrent myocardial infarction and increase of coronary heart disease events. So we have very strong data that are confirmation that if we are not adherent to statin therapy, if we have patients with statin intolerance, those patients are at a very high cardiovascular risk. So it is especially important now because we know it very well that according to the recent guidelines that Professor Zeljko Reiner has just presented, there is a very strong message that the lower is better, and for very high risk patients and high risk patients, we should be below 70, below 55. But the question is how to do it effectively in patients with partial or complete statin intolerance. We should always think about the nutraceuticals. At the end, I would like to present you a kind of a step-by-step approach for patients with partial and complete statin intolerance. But we need to know what nutraceuticals we have on the market have indeed and might have indeed lipid-lowering properties. And obviously, our position paper we published in 2017 was a kind of attempt to summarize for the first time the nutraceuticals with evidence-based medicine concerning the lipid-lowering properties. But on the other hand, at American Heart Association Congress last year, we presented for the first time a network meta-analysis that make a kind of rank prioritization of those nutraceuticals with the largest effect on lipid-lowering therapy, especially on LDL cholesterol. And as you can see, the largest effect is for polycosanols for radius rise, berberine, spirulina, and artichoke. So we should first remember those nutraceuticals because based on their lipid-lowering effect, we might still expect a significant reduction of LDL cholesterol. What is important? This is part of this position paper we published with Arrigo, with Niki, with Professor Zeljko Reiner in 2017. And as you can see, we made an attempt at the recommendation of class and level of recommendation. We also noticed that for most of nutraceuticals, it is not only the effect on the LDL cholesterol, but something I usually call a kind of pleiotropic effect, because nutraceuticals usually do not have a very selected property associated with LDL cholesterol, but also they work for other parameters such as inflammation, such as vascular stiffness, and so on. It is very important concerning not only LDL cholesterol, but also residual cardiovascular effects. But what I would like to kindly emphasize, that if we think about the efficacy, lipid-lowering efficacy of nutraceuticals, we should first of all think about the nutraceuticals combination. So we should combine the nutraceuticals we have on the market with the confirmed evidence-based medicine concerning lipid-lowering properties in one polypill, and we should try to use those polypills for very high-risk patients, including patients with statin intolerance, because most of them are very high-risk patients. One critical issue, it is something that probably a little bit completed the previous presentation by Professor Zeljko Reiner. We have had data for radius rise, for monocolin K, that it might be very useful in patients even at a very high cardiovascular risk after MI. And as you can see in this study, the dose of monocolin K that was used in the preparation of the radius rise was between 2.5, 3.2. The follow-up was about 4.5 years, and in the end it was associated with a significant reduction of the cardiovascular outcomes. Obviously, it was a kind of study that probably would be very difficult to repeat now in 2020. It was designed in 2006 and published in 2008, because we now much more effective drugs such as statins, such as ezetimibe, such as PCSK9 inhibitors, and we know it very well that if we are not effective with the reduction of the LDL cholesterol with those drugs, we should consider another drug in order to be on target. We should consider another drug in order to be as low as possible and as early as possible with the LDL cholesterol target. Okay, what is more, in 2018, for the first time, we made an attempt to prepare a kind of recommendation which nutraceuticals in fact might be useful in statin intolerant patients. We know it very well that there is a large difficulties with the definition of statin intolerance. We know it very well that there is a problem with the placebo effect. We know it very well that we first need to exclude the condition, that risk factors that might be associated with the statin intolerance. But in the end, we should first of all effectively treat those patients, especially if we have a complete statin intolerance, especially if we have patients with the increased creatine kinase and we are forced to discontinue statin therapy. And what nutraceuticals we might consider then, and we have evidence base in these patients with statin intolerance for those nutraceuticals. It is obviously radius rise. However, there is a large discussion between different experts, because it is a small dose of lovastatin, if we have a complete statin intolerance patients, should we consider these radius rise in those patients? I will show you in next slides that we have a data, very strong data, that in complete statin intolerant patients using radius rise, it means very low levels of monocolin K and natural lovastatin is not associated with the high increase of the statin associated muscle symptoms. In fact, this risk is less than 0.1%. So it is indeed very useful preparation, and it is not surprising because it is a very small dose of very less potent statin, what is lovastatin. Besides radius rise, we have obviously bergamot, which is also very useful. As you can see, it might be associated with the reduction of the LDL cholesterol by 15-25%. We have soya products up to 10%, and we have omega-3 acid. It is very small effect, but it's still important, up to 7-10%. What about this data I've mentioned? It is one of the studies that you probably have already seen by Professor Giuseppe Rosano group. And we have, first of all, combination of the nutraceuticals in one tablet as a polypill. As I've mentioned at the very beginning, it is probably the gold standard we should consider for patients with statin intolerance. So we have a radius rise, policosanol, berberine, folic acid, azaxanthin, and coenzyme Q. And as you can see, altogether it was associated with the 31% mean LDL cholesterol reduction after 12 weeks. Whether it is large or not reduction, if we have a patient with statin intolerance, so we cannot use statin at all, or we can use only low dose of statin, because please remember that for 95% of our patients with statin associated muscle symptoms at the very beginning, when we try to use statin at the lower dose every second or every third day, we try to use different preparation, we still might use statins for 95% of those patients with the baseline sums. But if we add nutraceuticals, we might still have an additional 31% reduction of the LDL cholesterol. And for some of those patients, those patients might be on the target of the LDL cholesterol. Obviously, in 2017, the target for those patients after acute coronary syndrome with previous coronary event, in fact, it was below 70. So probably now it would be probably less than 50 or maybe 40%. But it is still having the opportunity of using polypill of nutraceuticals, especially with the combination with ezetimibe, we might still expect a very significant reduction of the LDL cholesterol and having those patients on LDL target. It is the slide I have already shown you at one of our previous ILEP webinars, but it is a very important slide made by the group by Professor Claudia Stefanutti from Italy, because it is the confirmation that nutraceuticals might be useful in patients with familial hypercholesterolemia. So these are patients, in fact, at a very high or very high cardiovascular risk. And these were patients with FH and statin intolerance. And as you can see, after 12 months of follow-up, the LDL reduction was even up to 40%. Obviously, it was the combination of nutraceuticals, it was monocolin K with ezetimibe, and obviously those patients were very well followed concerning the diet. It was a cholesterol-lowering diet. So having diet, ezetimibe, and combination of nutraceuticals, we might even have 40% reduction of the LDL cholesterol. So it is a very similar to moderate statin intensity therapy. So I believe it is a very important opportunity for those patients with statin intolerance. What about whether it is such a therapy is safe or not? I don't want to focus at all, but I would like to only show you one slide, which as a confirmation that if we consider patient with statin intolerance or not, we have the same effect concerning the safety. So don't worry to use radius rise, which is now after the EFSA scientific opinion paper from August 2018 up to 3 milligrams only, that this drug, this preparation, this supplement of radius rise might be associated with the additional statin-associated muscle symptoms. Okay, what about the International Lipid Expert Panel guidelines or recommendation of statin intolerance? It is a kind of we use the kind of approaches which is very easy to follow. It is the first approach is this, and this is associated with the suitable diagnosis of statin intolerance, because it is we should always think about the timing. So usually the statin intolerance appear in first 12 weeks after the starting of statin therapy, of increasing the dose. We should always think about the history. So we should always ask whether it was a problem with the toleration of statins with in other members of the family. It is we should use also SAMS clinical index protocol by Bob Rosenson and National Lipid Association, because then we have a kind of causal effect between the muscle symptoms and muscle pain and statin therapy. And obviously severity and tolerability is important. We should always ask about the tolerability, because based on then we know that we should stop or we should consider continuation of statin therapy with the reduction of the dose, with the changing of the preparation of the statin, with the adding of the ezetimibe. And as you can see, if we look at the step-by-step approach, what to do in those patients, at the very end, we have immediate opportunities to use ezetimibe, PCSK inhibitors, and nutraceuticals. Unfortunately, in Europe, for most of those patients with statin intolerance, we do not have opportunity to use PCSK9 inhibitors, or they are very strict criteria in order to use PCSK9 inhibitors. So in fact, for most of those patients, we have ezetimibe and nutraceuticals. And this is one of the very last slide, because I do not agree with this statement and consensus of the European Society of Cardiology and European Atherosclerosis Society, because as you can see, based on those recommendations, if we have patients, symptomatic patients with CK below 4 and over 4, which are symptomatic at the risk of rhabdomyolysis, we treat those patients for the same in the same time, in the same manner, because there is a suggestion of the discontinuation of the statin therapy. And I believe for this group of patients, for most of those patients, we should not consider discontinuation of statin therapy, and we should consider trying to monitor those patients, ask about the tolerability of the pain. And I believe after 4 to 6 weeks, for most of those patients, we would be able to use at least low dose of statin. For those patients, we should immediately start another therapy, because when we stop any lipid-lowering therapy for 2 to 6 weeks, it might be associated with the lipid LDL visit-to-visit variability and increase of the risk of the cardiovascular events. So that is why in this step we should immediately recommend, and it will be present in the ILEP recommendation on how to manage with patients with statin intolerance, immediate ezetimibe and nutraceuticals, or ezetimibe plus nutraceuticals and PCSK9 inhibitors as only it is available, because then we have at least our patients will be at least safe concerning also the reduction of the LDL cholesterol, even though this reduction will be not at the same level as it would be after statin therapy. It is at the very end, it is a very important case report, I believe, because it is my colleague, professor of endocrinology. It was a person with BMI, as you can see, with overweight. It was a blood pressure, which was, again, as a borderline blood pressure, with no family history, with no diabetes, with no regular exercises, unfortunately, but it's very typical for physician, with no drugs, with no secondary causes of dyslipidemia, however, with unhealthy diet, which is unfortunately also very, very common between physicians, and with mean LDL cholesterol level 100 LDL cholesterol level 156, with lipoprotein(a), which was on the target. And as you can see, at the very beginning, risk score was 3. So it was patients with moderate risk of cardiovascular events. So we know very well that it should be below 100 now. We know it very well that taking into account the level of the LDL cholesterol 156, we have no chance with non-pharmacological approach to be on target with these patients. So that is why we started with atorvastatin 10 milligrams in order to have a 30% LDL reduction. Unfortunately, it was a significant increase of CK. due to the fact that we excluded all the other adverse conditions and risk factors that might be associated with statin intolerance, we started with ezetimibe and armolepid plus immediately, because we know it very well that we do not have chance and to try another statin to have a reduction of the dose, because my colleague was a very busy man. So that is why after ezetimibe and armolepid plus, after 3 months, after 2 months, he was on the target, because LDL cholesterol level was 95. So as you can see, it is a real life case. We might be effective with the nutraceuticals in patients with statin intolerance. So thank you very much. My apologies for being a little bit delayed with my presentation, but I am very glad that Arrigo is with us, because I gave Arrigo very difficult topic. Arrigo, my apologies for this. I hope you are not angry with me, because Arrigo would like to say a little bit more about the very specific group of patients at the risk. So patients with heart failure, with the elevated inflammation. So Arrigo, the floor is yours. I'm looking forward to seeing your presentation. Thank you very much.
Thank you, Maciej. Thank you for everyone for the attention that you will give to us in this evening's webinar. And as Professor Banach said, this was not a very easy topic, but I will like to just to say to you a summary of the evidence that we have when we can try to use the best of our knowledge on pharmacological activity on natural products in changing and modifying some parameters in high risk patients. So just let me start with a paper, with the present introduction of a paper produced by the International Lipid Expert Panel Group a couple of years ago, where some colleagues, and among them even Professor Katsiki that is here with us, tried to summary the evidence available on the potential lipoprotein A lowering activity of some natural products. And it is very difficult to work in this context, because we have some signals from the literature that many natural products are able to lower, from a statistical point of view, the plasma level of lipoprotein A. And just for instance, the main problem is that if we concentrate on the percentage reduction of LPA that we can see with a large part of these products, we can see some impressive decrease. But the most part of trials enrolling patients in this kind of studies were patients that had normal or nearly normal LPA at the baseline. So that's like to say that the most part of this patient has from 20 to 30 milligram deciliter of plasma level of LPA, and they dramatically reduce these values, but in the range of normality. In fact, if we see the absolute decrease that we can achieve with the most part of these natural products is relatively small. Anyway, relatively small is not like to say nothing, and we can also think that a part of these products have also other metabolic effects that could be also useful. I mean, for instance, the metabolic effect of a flaxseed, or the positive effect of coenzyme Q10 in energetic metabolism and protection from oxidation of lipoprotein and so on. And a particular situation is the one of the Zwickang, that in just one trial showed this impressive effect on LPA, but in other trials the same product that is based on radius rice was not able to repeat the same performance. So we have to point our attention that in the last years other trials have been published showing some protective effect against LPA by some natural products, and we have to try to increase our attention to this field. Just before to go quickly to the heart failure protecting agents, I wanted to stress also that the European Society of Hypertension in the last years have also published a position paper on the possibility that some nutraceuticals are able to reduce in a significant way the blood pressure. And I wanted to show that because the most part of this product are also possibly interesting for the management of a heart failure patients that I will say before after. And what I wanted to stress is that we have a lot of natural products that impact positively on blood pressure, and the support is based on meta-analysis of randomized clinical trials. Of course, the most part of this meta-analysis are relatively small, but one more time, the most part of these products are usually very safe. Many others working in the International Lipid Expert Panel are involved in trials on this product. And as you can see, I've divided just here, for instance, the food. We have the non-roasted green coffee, the pomegranate juice, the tea, the carcade tea, the beetroot juice, sesame are all associated with a significant blood pressure lowering effect. If we consider isolated nutrients, we can also hear that there is a strong literature support. Here, the meta-analyses are larger, based on a larger number of clinical trials. The effects are usually small, but always significant. And this is true for magnesium, potassium, vitamin C, probiotics, and even high-dosed omega-3 fatty acids. And then we have the pure, the one that I call the pure nutraceutical, the non-nutrient nutraceuticals, like for instance resveratrol, that we have also have some kind of effect on lipoprotein A before, the cocoa flavonoids, isoflavone, aged garlic extract, lycopene, pycnogenol, alpha lipoic acid, and so on, that all have even impressive effect on blood pressure. One more time, this effect is supported by meta-analysis of randomized clinical trials. This is overall interesting, even if we have to remember that in the most part of trials, and the very high dosages of these products are used that are not usually contained in the products that we find in the market, because the cost will be very, very high. So here the problem is not usually about safety, and even probably even not about the efficacy. But the problem from an ethical point of view is related to the fact that the cost of these products are usually much higher than the ones of the standard and validated pharmacological drugs. So, of course, we have to respect the choice of the patients and try to work with them on the quality of their choices, but we have also be aware about that. Going on with a very recently published paper from the International Lipid Expert Panel that I have coordinated about the nutraceutical support in heart failure, we have some interesting evidence that we can find really clinically measurable support from certain natural products in these patients. So, first of all, in any way, the nutraceutical approach could be substitutive of any kind of treatment that we have to do in heart failure patients. This is out of any kind of indication. But we have to remember that heart failure patients usually, even when very well cared from a pharmacological point of view, are always often bored by tiredness, residual tiredness, and they have physical limitation and so on. So we have a lot of products that have been clearly studied in randomized clinical trials. And first of all, the most well studied are coenzyme Q10, the flavonoid fraction from hawthorn, and omega-3 fatty acids. Then in a second level, we have L-carnosine, magnesium, vitamin D, L-carnitine, probiotics. If you see, they are the most part of the one that also lower blood pressure in some way. And then we have beetroots and cocoa dark chocolate, whereas vitamin C and vitamin A are even contraindicated. Here we have usually not meta-analysis of clinical trials, but we can have repeated clinical trials that are showing some kind of positive effect on heart failure patients. And I usually focus my attention on the self-perceived quality of life as a main outcome. But we have also to say that where other instrumental parameters have been reported, they usually relate with improvement of quality of life. So I think always that our main outcome is to treat, to improve the instrumental parameters through pharmacological therapy. But even if I can find something like coenzyme Q10, D-ribose, or L-carnosine that are totally safe, and if I can find any kind of improvement, it could be also nice. As I said before, the botanicals are a little bit less evidenced. We have here the beetroot and the cocoa, I said before, and but the most studied are, of course, the flavonoid fraction of hawthorn. Where is the problem with hawthorn? Hawthorn for many years was also included in the German guidelines for heart failure management as a supportive treatment, but based on trials that have been carried out where the pharmacological treatment of heart failure was not so very well characterized and standardized as it is now. So this is something that we have to remember, because probably we can find the same impact that it was seen 25 years ago in the trials measuring the effect of hawthorn on hard outcome in heart failure patients. As you probably know, we have also a single case of a nutraceutical tested on hard outcomes in heart failure patients, that is coenzyme Q10, where the forms with the high bioavailability and the high dosages are able to halven the all-cause mortality and hospitalization in a patient treated at the best of the current guidelines treatment for heart failure patients. So even there, this kind of the treatment is very, very expensive, and so we have to understand where and when we can apply it. I thank you very much for your attention, and I hope that my lecture was in some way interesting.
It was, Arrigo. Thank you very much. It was a beautiful lecture that presented indeed the groups of patients that we usually have not considered concerning the use of nutraceuticals, so especially heart failure patients. And you remember our discussion that whether we should present this data. But on the other hand, when we look at the data, that in fact heart failure is a consequence of the risk factors such as lipid disorders, MI, such as hypertension, in which we have a confirmation that nutraceuticals might be useful. In fact, I believe it might be a kind of supportive therapy as well. We will discuss it further, because we have first 5 questions, and I would like to kindly ask all the participants in order to write your question, because just after the lecture of Niki, I believe it will be a great time in order to answer all of those questions, because they are very difficult, as I can see. So it will be a great challenge to answer them correctly. So Niki, now the floor is yours. What about the safety of nutraceuticals? Whether it is so easy to say it is safe or not, or maybe it is some issues that still need to be discussed and followed with the further studies.
Hello, good afternoon from me too, our dear friends and colleagues. First of all, I would like to congratulate Maciej, Professor Banach, for his great initiative of creating this group of experts around the world on lipidology. So ILEP, International Lipid Expert Panel, is really important because only if we're united and we can share our experiences and our research, we can help indeed our patients with dyslipidemia in our daily lives in clinical practice. So it's my honor and of course a pleasure to be a member of this great team and together in this evening to have this excellent webinar with so well-known expert and well-recognized from around the world, like Professor Reiner and Professor Cicero. So I'm going to talk about nutrivigilance. And of course, after my declaration of interest, so we are trying to do a lot in research, but also in clinical practice. I would like to say that always safety comes first. So maybe this was the last lecture for this night, but we must remember that safety comes first. Of course, we want efficacy, it's really important in our patients, but safety indeed comes first. Now, what about nutrivigilance? Some of us may have heard this term relatively in this only a few days. So what about nutrivigilance and research on this term? So if you click the term nutrivigilance in PubMed just today, just a few hours ago, you can only find 8 reports. And these are reports from 2020, from 2018, 2016, 2015, or 2014. Whereas if you have pharmacovigilance in PubMed, you have more than 9,000 reports. So we have a lot of road to go on nowadays regarding nutrivigilance. So why do we have to talk about nutrivigilance and study nutrivigilance? There are many reasons. So the reasons, first of all, is because there is a steady increase of the use of food supplements in this last decade in our countries. And of course, we know that many of these ingredients which are contained in these products have a pharmacological activity. And actually, our drugs, usually the development of a drug may, especially in the earlier times of drug development, was from extracts from plants and from the nature. So we know that a lot of these ingredients may have pharmacological activities. So it's important also to check their safety. Of course, there are some cases raised from other vigilance systems. So some patients may report side effects of a food supplement, but they first contact the pharmaceutical companies if they use other drugs. But if you discuss with them, then you may end up with a side effect of a food supplement instead of a drug. Also, there is the need from the authorities in a way to create legislations and laws about safety limits for the use of these substances. So the dose, how many you can combine, and of course, depending on the patient subpopulations and on what other drugs these patients may also take. So it's really important to study nutrivigilance more and more nowadays, and of course to create a certain system to facilitate the process and also to monitor the use of these supplements, the safe use of these supplements. So back in 2002, this was the first step to the development of nutrivigilance. So there was, for the first time, an adoption from the European community regarding the regulation for food supplements, and a department specialized in the safety of food supplements was created. And then the nutrivigilance system started to be developed in certain European countries, and especially in France. And safety laws to protect the consumers from food supplements were started to be developed. So in this European let's say, legislation back in 2002. There was a definition of food supplements involving substances that are used together with a normal diet from the patient that have a nutritional or physiological effects and are marked in a dose form. So it's really important that this is, we understand what the food supplement is in order to talk the same language and understand each other. And usually they use small unit quantities in these food supplements. Now, I really found very, very useful in terms of discussing nutrivigilance what has been created by the French Agency for Food, Environmental and Occupational Health and Safety. So this department is the most well-developed nutrivigilance department all over the world. So they have also a website, and you can find even more interesting stuff inside there. But their aim is to improve the consumer safety in terms of nutrivigilance. So they discuss about safety issues on food supplements, foods or beverages that contain substances of nutritional or physiological purposes, for example, vitamins, minerals, extracts, plant extracts, amino acids. Also about novel foods and novel ingredients like phytosterols and non-nutrients, and also products intended as food for special categories of the population, for example, for athletes, which is a huge discussion about athletes and supplements used for athletes and for marathons and for any other sports activities, but also in patients with food allergies and also in children and infants. So it's really important also to study the special populations in relation to nutrivigilance. So nutrivigilance, we could say that is like equivalent to food vigilance. It's really important to understand that. And also the reports are used by this department in terms of severity, assessment of severity of any reported side effects, but also assessment of causality, which is the main issue. So the main problem is how we can really find a causal link between any reported side effect and the food supplement taken by the patient, because another reason may be there, and there may be a misconception regarding the causality of the reported adverse event in relation to a certain or certain food supplements. So there is a committee that has to observe and record all these effects and to analyze the data that are recorded by this committee, and this can lead to a scientific opinion and recommendations, which is a strong evidence-based result of this data collection. So it's really, of course, important to avoid taking for a long-term, repeatedly or multiple dose of supplements without seeking advice. So the main thing also here is that whenever a patient is going to take a food supplement, he or she should seek advice from his or her attending physician. So it's really important to understand that the problem is not on food supplements. The problem is on the use of when, how much, for how long, and why, and for whom you give this prescription. So it's not the pharmacist who's going to decide, it's not the patient who's going to decide, it's the doctor, the attending physician who's going to decide about the use of food supplement. It's really, of course, important that the patient should follow the instructions of how to use this food supplement based on data available from the manufacturers, and of course based on the instructions given by the attending physician. And also, of course, it's really important for the patient and for us also to report any adverse reaction. So we need to keep reminding to our patient that please, if you have any adverse effect or any potential feeling of something going wrong, please contact us, and so that we can also inform the authorities and see if this is really an adverse event or not of the food supplement. So there are different participants participating in this nutrivigilance system, and all of these participants should collaborate and work together in order to have safe conclusions and safe data and reach safe scientific opinions and safe recommendations. So it's really important not to have fear for food supplements, but to use them and with attending and monitoring the patient in order to see if there is any safety issues. All these stages will lead to the formation of scientific opinions and recommendations. So this agency in France use certain scores to evaluate the causality of any reported adverse effect in relation to the use of a food supplement, and they use intrinsic and extrinsic score. So extrinsic has to do with the literature, if there's a pathophysiology explanation for the reported adverse event in relation to the ingredients of the food supplement taken, whereas the intrinsic score has to do with more clinical data regarding when and for how long the adverse event was there, and if something else, there's any reason other, maybe the patient has taken some other drugs or other food supplements, or has a stress or another condition that may have changed the reason for the side effect reported. So they use these scores, as I said before, intrinsic and extrinsic, and with this score they result in any causality relation indeed reported in this registration. But of course, it's not only the causality, it's the severity that it's very, very important, and it is taken into consideration. So a severe adverse event is, of course, more important than a less severe adverse event. And recurrence, of course, when you stop the food supplement and the side effect stops, but then when you reinitiate the food supplement, the side effect reinitiates again, then this is, of course, some evidence on the causality of this link. So there is, fortunately for us, there is a network about nutrivigilance started about in 2014. Certain European countries have already been linked in this network. Unfortunately, I come from Greece and I don't see Greece in this network, but I will do my best, being also a member of the Executive Council of the Hellenic Atherosclerosis Society, to also be a part in this network, which is really important, because the problem is that due to this fear of side effects, maybe some patients, a lot of patients may not be able to take the food supplement that will be indeed needed for them, and that they would help them to improve the treatment efficacy on lipids, for example, because there are fear for side effects, whereas they should benefit from the use of food supplements in certain patient populations, as we have heard before. So it's really, really important to have this network more and more expanded by the years in order to have really safe data. Also, what is really interesting, there was a survey regarding the reports of side effects in relation to the use of food supplements, and you can see here that mainly the majority of the reports, 76% of them, were related to food supplements and not to other only foods or special diets. So food supplements may have indeed some side effects, so we have to take that into consideration. Of course, women, because they most usually are the ones who use the food supplements, but also, you can see that they are the most ones who report side effects, maybe because also for hormonal reasons, I don't know, we have to search for it. Also, we see that the manufacturers indeed do some good work on that and report in this system any potential side effects, whereas only a small minority of the doctors report side effects on the use of food supplements. So I really urge our friends and colleagues worldwide to be aware of any potential side effects of drugs, of course, but also food supplements, and report them to their authorities. So also, what was really interesting for me, and I would like to share this with you, was that the main problem came from creams about, weight reduction or hair care or nail care. So there's no problem with lipid-lowering drugs or food supplements in specific. But other cosmetic supplements used usually have also problems. So it's not only about lipid-lowering, but we should remain in our minds that there are other supplements used for other reasons, and we need to take this also into consideration. So we have some gaps in European legislation regarding nutrivigilance, but fortunately some countries, especially France, the Czech Republic and the USA have started to do a lot of work on that, and we are there to support them, but also to be able to also, if we can, have an opinion and recommendation as ILEP would be really nice to collaborate with such legislation systems. Also, we have a lot of, I'm not going to go into details regarding which food supplement may have which side effects. This is something to consider in another webinar. And I would really like to also point out, sorry, let me take a step back. Okay, no. I would really like to point out that it's really important to find the dose of the food supplement that may create adverse effects, so the lowest observed dose, but also to find the upper level of a drug, of a food supplement and the side effects that they create, and also to find the recommended intake level for the population to prevent any problems with safety. So what I also would like to share with you is that, as you can see here, as the time passes by, more and more data are gathered. So we have more and more data on that issue. And also, it's really important to have a post-market assessment of products of food supplement safety and a robust framework for nutrivigilance to gather safe results, as I said before. Now, I urge our friends and colleagues to read, as Professor Cicero also shared with you, the expert panel recommendations on the use of lipid-lowering nutraceuticals. You can even find them for free in Archives of Medical Science, and many congratulations to Professor Banach for the gradual increase in the impact factor of this excellent journal where he is the editor-in-chief. Many congratulations, Maciej, for that too. And to conclude, I could not just not say any word for COVID-19 pandemic. Even nowadays in COVID-19 pandemic, it's really important to consider the use of nutrition, the use of food supplements in order to address the needs, the nutritional needs for patients and help them to improve their therapy and the recovery at all stages of infection. So maybe some of these patients are using food supplements, or maybe some food supplements should be used in these patients even in the phase of the acute infection or during the recovery in order to replace the needs of nutritional food. So I would like to conclude being Greek also that as Hippocrates, our father of medicine, told that let food be the medicine, nowadays maybe nutraceuticals may be our medicine to use. Thank you for your attention.
Thank you very much, Niki, for a beautiful presentation on safety. I know everything now about the safety of nutraceuticals for 100%. But one thing is, I believe many things are important from your lecture, but one thing is not only Greece, but also Poland is not included in the consortium. So I believe it is also a great challenge before Poland in order to be a part of this important consortium to take care of the safety research on evaluation of investigation of safety of the nutraceuticals. I believe it is a critical issue. On the other hand, we should probably remember that we do not have the same opportunities in order to evaluate the suitable dose, the most optimal dose of nutraceuticals concerning the efficacy, but also concerning the safety. As we have, for example, in phase 2 and phase 1 randomized controlled trials, because these are completely different way in order to introduce the nutraceutical on the market. So I believe it is completely different approach. But on the other hand, does not mean that we should not look into the most suitable dose of nutraceuticals that have efficacy, but at the same time it is the lowest possible risk of adverse effects after the nutraceuticals. So, you know, we have questions. So I believe it is the highest time in order to start questions. We have 6 questions. One thing I would like to ask at the very beginning, before the questions, because one of the most important issues concerning radius trials, for example, when we consider to using them as an add-on to lipid-lowering therapies, when we are close to the target, or we do not have other opportunity in order to use any other drugs after statins and ezetimibe, for example, PCSK9 inhibitors, is the discussion whether we should use radius rise as a triple therapy with statins and ezetimibe, having in mind that, in fact, radius rise is also statins. So we have two statins, because the baseline statin, ezetimibe, and a triple drug is another statin. Obviously, it is less potent with very small dose, but in fact, it is statin. And most of my colleagues usually say, come on, don't use nutraceuticals and especially radius rise as a triple therapy, because then, in fact, you are using two kinds of statins. What is your opinion about that? Because I have my opinion, but I would like to first to hear your opinion. Whether it is a problem, especially if we have patients which we would like to have on the target, as patients with incomplete statin intolerance, or maybe we should rather avoid this situation because we do not have enough data. What is your opinion about it? Arrigo, Niki, Zeljko, what? I don't want to finger out the person who would like to start, so please do.
So if I can, I think that this is a very intriguing question, because from one side, I say that from my first point of view, I also agree with the concept that if I can increase the dose of the statin that I'm using, I have to do that before to try to make some kind of interesting and alternative addiction. But anyway, we have also to consider that the problem from a safety point of view could be when we use high dosage and very concentrated formulation with radius rise, where they are much more similar to lovastatin than to a real dietary supplement. While when we use a standard product at low dosage, we have to consider that the radius rise doesn't contain only monacolin K, that this is the main focus of our attention usually, but it contains at least 10 different kind of monacolins that have different allosteric and pharmacological interaction with the tridroxytrimethyl-glutaryl-CoA reductase. And so I think that they could give their kind of a small contribution to the improvement of lipid control, but always considering the principle of the maximal safety for the patients.
Okay. Zeljko, Niki, any comment from your side?
Maybe I think it's very important to define which patients would actually benefit most from adding nutraceuticals, monacolin K, radius rise, or combined pill, as we have discussed. Indeed, probably those patients who are, as you have very elegantly presented, who are statin intolerant, because it is a reality that we do have statin intolerant patients who, despite the fact that radius rise, monacolin K, actually is low dose lovastatin, but still, you have mentioned this, we have seen that it does not have adverse effects as some of the statins do have. So such a combination can help definitely in statin intolerant patients, particularly if combined with ezetimibe, for instance. Why is this also very important? Because in many, at least European countries, including my country, the national health security system is reimbursing PCSK9 inhibitors only if you have either maximum tolerant dose, so meaning that you have intolerance for statins, plus ezetimibe, and not reaching a certain target, no matter target the insurance is going to pay. So in these cases, this combination plus statin and ezetimibe might be useful. And as you have also mentioned, maybe those patients who are very near to the goal, but still not reaching goal, and not in very high risk or extremely high risk. And so again, this might be helpful.
Yes, of course.
Maciej, I would like to add that for us as lipidologists, our main target is to achieve the target. So achieve LDL cholesterol levels for each individual patient. So no matter what you will use, no matter the way you achieve that, and until now, all our evidence is for the statement that the main target is to reduce LDL cholesterol. This would be with a nutritional approach, which would be with statins, with ezetimibe, PCSK9 inhibitors, nutraceuticals, food, physical exercise, I don't care. So the main issue is that we use every possible weapon in order to achieve our target for LDL cholesterol. And unfortunately, in many countries, PCSK9 inhibitors are not reimbursed, or even as Professor Reiner said before, also in Greece, they are only reimbursed in very, very specific patient populations with an LDL level starting from up to 100 milligrams per DL. So, I mean, it's difficult. So we have a lot of patients near their target, but not achieving it. So their nutraceuticals can really help.
Thank you very much for this statement, Niki, because in fact, I wanted to give you a concrete case, because if you have, for example, a patients which have after acute coronary syndrome, which have after intensive statin therapy and ezetimibe, LDL cholesterol level 74, it is a case from my clinical practice, and these patients take into account the reimbursement criteria in Poland, does not have a chance in order to be on PCSK9 inhibitors. In fact, I started for these patients nutraceutical, which wasn't radius rise, it was a bergamot, and these patients after bergamot was on the target before 55. So it is a kind of example that Niki said that we should try our best in order to be on target with LDL cholesterol. And obviously, these are very specific situations. When we are close to the target, we do not have other opportunity in order to use any other drug in order to be on target with our patients. But in fact, if nutraceuticals might help, then we should consider them often. It is the same with radius rise, because obviously the discussion is lovastatin and other statin, but we do have papers by Giuseppe Rosano, but by others, when they use already low-dose statins with radius rise, a combination of radius rise with other nutraceuticals, and it wasn't associated with any other adverse effects to this triple therapy. So I believe it is a kind of option we should have in mind, obviously, but it is very difficult, in fact, topic, because I believe you agree with me. We should not expect, on the other hand, a randomized control trials or well-designed studies to evaluate this issue, because these are nutraceuticals. So I believe that some of maybe retrospective or maybe prospective studies are possible to evaluate it. But it will be always the issues that we should say that, okay, we have limited knowledge. We will say probably in next few years that we will have limited knowledge for it. Okay, but we have questions. From Paolo, could you please comment? I believe it is a very kind of questions which is in line with our discussion now. Could you please comment where are we with the validation of add-on therapy with nutraceuticals on top of drugs for dyslipidemias? Arrigo?
I think that the data are most preliminary, and we can have some kind of meaning on the basis of our knowledge on pharmacology. We published a couple of papers on that, and in particular one paper a couple of years ago, where we showed our empirical evidence in our center on following the concept that Professor Katsiki said before, that's like to say, try to do everything you can to reach the LDL target. And we have put together different kind of nutraceutical on the maximal tolerated statins with some kind of good evidence that they can help to reach this kind of target, especially in primary prevention patients. But when we published also our international lipid expert panel paper in the 17th, we also tried to resume all the available evidence of tentative treatment, tentative combination treatment of nutraceuticals with drugs. We didn't find very, very much tentative by the researcher around the world, but we have selected some positive interaction in this sense with the combination of some nutraceuticals and drugs. So the only thing that I always would like to stress is that when we work with reduced rice, when we work with berberine, we have substances that are active at relatively small amounts. So it is relatively easy to add this to even a complex treatment without too much complicate the whole polypharmacy, because we have to try to avoid to include 3, 4, 5, 6 pills more in a very complicated therapy that the patient has a really very, very difficulty to follow. I think that this could be put in mind. So, for instance, very good reduced rice, very good berberine, just a little bit less good phytosterols that are very, very safe, but they need usually 3, 4, 5, 6 pills per day to reach just a small reduction in cholesterol. This is my opinion. Of course, I think that the colleague could also say something different.
Zeljko, Niki, any add-on to this commentary by Arrigo? If not, I would like to only emphasize very important issue that we have already done concerning this validation, because as Arrigo said, we usually have very small data, so, take into account small number of participants, take into account this short follow-up. But if we put all those data into meta-analysis, and we did for several times, we have a very clear information concerning the one we published on safety, when we also confirm that the combination of nutraceuticals, and add-on to statin and so on might be effective and safe. On the other hand, please also look at our International Lipid Expert Panel position paper, in which we also presented the data on the combination of validation, let's say, of the using of nutraceuticals as an add-on to statins, as an add-on to ezetimibe, and so on. Obviously, it is always not enough in order to be 100% sure it is effective, it is safe, and so on. But on the other hand, I believe it is enough in order to consider it always as a kind of something we might consider for lipid-lowering therapy. Okay, I'm looking at Niki and Zeljko because they are so calm. If they would like to add something.
What I would like to add is that I'm very confident, and I hope that the future will agree with me what I'm going to say now. I'm very confident that because a lot of data are gathered nowadays on nutraceuticals, more and more data coming every day on that issue, I do believe that we will have even more how can I say, legislation in a good way for the use of the nutraceuticals in the European and the American and the international societies on the use of nutraceuticals, not only for lipid lowering, but also maybe for diabetes, but also for diet, for cardiometabolism overall. So I do believe that as time passes, we will hear about nutraceuticals more and more from the societies, and this will help even more physicians to use these really helpful weapons, as I said before, our allies in our daily fight to achieve the best of the cardiometabolic health for our patients.
Thank you, Niki. Okay, because we have more and more questions, one is very important, the second one from Leila. Do nutraceuticals have an application in nephrology, because we have already discussed the heart failure patients, we've discussed inflammation, lipoprotein little I, come on. So maybe nephrology is also the group of patients we should take care concerning the possible useful application of nutraceuticals. What is your opinion about it? Because I believe it is quite easy to answer, because from my point of view, but my apologies, I'm a very talkative person. If we consider nutraceuticals for hypertension, we might also consider for hypertensive nephropathy. If we consider, if we know that some of the nutraceuticals have hypoglycemic role, so diabetic nephropathy. So I believe there is some properties of nutraceuticals that might be useful in nephrology. But what is your opinion about this very concrete question, in fact? Zeljko, what do you think about it?
Well, I would like to say something that we did not mention so far, and this is the fact that we have a part of our patient population that is reluctant to take so-called chemical drugs. This is reality. No matter what you or me or all physicians think, they simply do need some treatment for their hypertension, for their dyslipidemia, and they are reluctant to take something that they think is synthesized, is chemical, artificial, whatever you want, to whichever expression they use, and but they would gladly accept to be treated by something, again, in parentheses, natural product. And this part of our patient population is relatively big, and it's growing, and we have to face it. We are trying usually to convince them to use standard medication, statins or statins plus ezetimibe if needed, and so on. But a number of them simply do not want to take these pills, but if they need to improve their lipid status, and if they are willing to take something that they consider as a natural product, I think this part of the patient population is also important, let's say, for such a treatment. And this is a reality that we see, I think, all of us in everyday life when working with patients. So, as Niki said, the most important thing is to decrease LDL cholesterol, or to paraphrase the saying, it's not important what is the color of the cat, it's important that it catches mice. So whatever can decrease LDL cholesterol in patients who have increased LDL cholesterol and decrease their cardiovascular risk is okay.
Okay, thank you very much. I believe it is a critical comment, because I don't know if Arrigo and Niki also agree with me that, and with Zeljko, that we have more and more patients in our everyday clinical practice that usually say, okay, doctor, I agree, I understand that I have a elevated level of LDL cholesterol, but I feel healthy. I do not have any other conditions, for example. I do not have established coronary heart disease, and I don't want to even think about statins. There is no problem for me to approve natural products, the diet, the lifestyle changes, but I don't want to, I'm not willing to use statins. And this is a group of patients, in my experience, even about 5 to 7%. It is something which is a great challenge concerning the lipid-lowering therapy and optimal lipid-lowering therapy. Arrigo, Niki, what is your opinion about it?
So what I would like to add on that is that indeed, at least nowadays, we are moving more and more towards a more natural way of living. So we see in our countries more and more people selecting in their daily life more natural products overall for their hair, for their bodies, creams or whatsoever. So they really want, there's a coming back to nature. So it's really important for us as physicians, but also as researchers. So this is the important role of ILEP here, that we listen to this need of our people, of our patients, of our citizens regarding the use of more natural products. So this is in our hands nowadays. So we have a, how can I say, it's a responsibility in, as I said before, not to lose this opportunity to have whatever we can to help our patients to reduce their lipid, the LDL cholesterol levels or whatsoever, to promote their health overall with the use of certain products that are, how can I say, there is data for them, as we, as ILEP have published a lot of recommendations on that, used in a certain patient population, in a certain dose, and with certain instructions of how to use them. So I think it's really important for us to listen to this need of our patients and help them, and also help ourselves, because nowadays the patient has an opinion. And it's really important to listen to the patient. So the patient has a central role in their treatment plan. So all the societies also support this patient-centered approach of therapy. So we need to listen to them and help them and come together with them, more close to them, and indeed use natural products in some cases or in combination with drugs at a lower dose in order to help them achieve the target.
Arrigo, any add-on?
Yes, I also agree, and this is a great challenge that we have, and a great responsibility also as well, and even more, if I can be a little bit critical also about the fact that the people will like to be carried with natural cares and so on, but then often they don't want to spend about them. So that I like to say that they want to be treated with something natural, but low cost. Low cost in this concept is like to say often, to have products that are not standardized, that are not checked about mycotoxin or hard metals like nickel or lead and so on. And so it's like to say, I want to spend less, but I also accept to risk more. And this is very relevant, I think. And as regards to your first question about the renal patients, the chronic kidney failure patients, I think that we have to be attentive, but we can have many opportunities. And I also would like to stress that in a medical field like nephrology, where the new medical treatments are very, very low, small and really, really hard to be found, anything that can improve the quality of life of our patients, and that is also tested, but often not known, like for instance, essential amino acids in nephrotic syndrome, or for instance, polyunsaturated fatty acids at high dosages for EGA nephropathy and so on. This is all nutraceuticals, and we often forget that they can be a good point to start to care these patients that we usually some patients only to be observed till they go on with their disease. So I think that there is a place. We have just to investigate and to enter in deep with our knowledge.
I totally agree. Yeah, sure, Niki. Yeah, please go ahead.
I'm brainstorming now. So I have an official suggestion to do.
It is quite normal for you and for me, so it is not a problem at all.
So I think it would be really nice if experts on nutraceuticals, like we have in ILEP in our family, would be invited from medical universities to teach in medical schools, because the medical students are the future of our medicine overall. So we need to treat them and to intrigue, to give the trigger for more research on that. So maybe it would be really nice. I can suggest it in my university. We can do it worldwide, to have from specialized people like ILEP people to do some lectures on nutraceuticals and research protocol on nutraceuticals.
Yeah, I totally agree, and obviously it is a great idea that we need to follow further. But two things in order to finish this part of the discussion. First of all, we should always remember, tell to our patients, and you agree with me, that is one of the first statements in our all nutraceuticals recommendation, that nutraceuticals cannot replace pharmacotherapy. It is one important thing. And the second thing concerning the nephrology, because I totally agree with Arrigo, that you please notice that for most of the lipid-lowering drugs, we do not consider them in patients with end-stage renal disease, with dialysis patients, and so on, because it is an issue. And obviously, I do not want to recommend nutraceuticals in those patients, but in fact, it is a kind of niche area of research that might be considered in the future studies, especially for natural products that should be safe. Okay, we have next comment, in fact, from Meryl. Meryl, it is so glad that you are with us. You are a great expert in the field of lipid disorders, and it is a great comment. In fact, I didn't know about it, that FH is highly prevalent in Turkey compared in all European countries, and this part of the statement I knew, but real statin intolerance is extremely rare. In my lipid clinic for the last 20 years, I saw only 13 patients per 6,000. So wow, it is something that I didn't know, because when I look at the registries, and I'm very familiar with most of the registries for FH and lipid disorder patients, it is usually overestimation of the statin intolerant issues. And I usually can see 30, 40, even 50% in one of the region registry I remember, which is indeed a great problem. But in fact, I didn't know that in Turkey it is in fact a very good situation, because most of the patients that require very intensive statin therapy and combination therapy, especially FH patients, do not have problem with statin intolerance. So they usually have a good approach to the most effective therapy. What is your opinion about it? In fact, when I look at my experience concerning the patients I usually have, and I have about 2,000 patients with statin intolerance in my clinical practice, the real complete statin intolerance is about 3% only. That I know that I do not have any chance to use any dose of statin therapy due to the fact that these patients in almost 100% have symptoms linked to statin therapy with the causal link, because I usually try to exclude all the other risk factors and conditions that might increase this risk. So thyroid disease, alcoholism, liver disease, and many other different things. So drug-to-drug interactions, so on. But in this, I can see about 3 to 5 patients per 100 with complete statin intolerance. And obviously, I can see about 20-25% of those with any other myalgia associated symptoms after statin therapy, that for most of them I can use statins after such a step-by-step approach. But what is your opinion about the prevalence of statin intolerance in your countries, in your clinical practice?
Well, if I might say, I fully agree with you about numbers. I think it's in real life, it's maybe about 3%. Top would be 5% real statin intolerance concerning myopathy. We are doing to these patients genetic analysis as well to prove this, and most of them do have genetic proof of being prone to statin intolerance. However, we know from everyday practice that this number, at least in my country, would look much higher, going up to maybe even 20%. But when you talk with patients, then you realize that they often think that some problems they have with joints, for instance, or some other problems, degenerative diseases and so on, joint diseases and so. When they read the leaflet, which is with statin, particularly if you apply highest dose of more potent statin, and when they read the leaflet there, they suddenly come to you saying, oh, I have this and this symptom, and so. And then if you take some time and discuss with patient, you realize that actually he or she had it for many years before starting with statin, and this is so-called pseudo intolerance. And I think this pseudo intolerance is something that bothers us all, because patients are convinced, they are reluctant to take statins anymore. And again, now we come again to this group of patients which might take nutraceuticals, because they are simply convinced that the statins do harm to them, although they don't in real life. But if they're convinced, and if you want to decrease the LDL cholesterol, you should use whatever means you have.
Thank you, Zeljko. Niki, Arrigo, and a brief comment, because we need to finish probably in 5 to 10 minutes. So about the real prevalence of statin intolerance in Greece and Italy.
In Greece, what I would like as a joke, but which is actually the truth, is that in the head of the physicians, there is even a larger percentage of statin intolerant patients. So in Greece, I would suggest that doctors would be more positive to give a lower dose of a statin plus ezetimibe plus a nutraceutical. I do believe that.
There we go.
Yes, I agree with you. We have a lot of people that I call psychostatin intolerant, and they are at least 50%. And then there are other causes that are attributed to the statins, like, for instance, joint disease or so on, that is totally unrelated. And probably the pure prevalence is about 3, maximum 5%, as Professor Reiner said. I think more 3, probably. Yeah. Then those are really, really tiring patients, because it's very difficult to manage them. But they are just a small part of them.
Okay, we have 2 questions. One of them is associated with the using of nutraceuticals in primary prevention. It was the issue of the first our webinar, which was on the 23rd of September. So it was recorded. It is available on the ILEP webpage. So in fact, it is the main area of using nutraceuticals besides statin intolerance patients. So primary prevention, yes. It is the place that we should consider always nutraceuticals if we are not adherent to lifestyle changes. So if you don't mind, I would not focus on this, and I would like to kindly ask Amani to see our recording. And we have a great comment again from Meral concerning the safety again, because Meral asks that most of us are not aware of the drug and nutraceuticals interactions, and it is true. And what do you suggest for physicians prescribing these agents? Where to get information about the safe doses and drug interaction and safety? And this is a very difficult question, Meral. As only you would like to kill us, but it is okay. We like you still. But on the other hand, our papers, International Lipid Expert Panel recommendation, where one of the aim was always also associated with the fact that we wanted to present the range of doses for which we have evidence-based medicine concerning the efficacy and safety. It was one of the issues and one of our aims of, and that is why we, in our papers, most of the doctors that would like to use nutraceuticals might find this information. It does not mean that this is the very last, and this is a very last message, because we are still looking at the new studies, new data, and probably will be able to update this recommendation in the next few years. But obviously it is a great issue, but because Arrigo, Niki, and Zeljko has already mentioned that we should always remember that adverse effects might happen after nutraceuticals, especially if there is a very large doses. It might be gastrointestinal. It might be, for example, after omega-3 acid. You know that the atrial fibrillation, there is a higher risk of atrial fibrillation. After radius rise, obviously we should have in mind that might be any muscle symptoms, adverse effects. So we should always have in mind, and we should monitor it. But however, if we compare it to pharmacotherapy, we should have also in mind that they are much less than in comparison to therapy. So it is my kind of answer for this very important question by Meral. But Arrigo, Niki, Zeljko, if you would like to add, because it is very important question that I believe we should a little bit focus at least few minutes.
If I may begin the discussion, because more or less this was my lecture. So as I said before, it's, dearest Meral, I will send her indeed the paper, but I really like the fact that the ILEP with Professor Banach decided also to publish the recommendations regarding the use of nutraceuticals for lipid lowering in AMS, Archives of Medical Science, which is free, that you can download it from the internet. And there you can see and find, up to date at least, the dose and the way to use, the safe way to use the food supplement. For example, before, after dinner, before, after, morning, or to eat or not to eat. So it's important also to read the manufacturer instructions, as I said before. So please, for physicians that are listening to us, please read these recommendations. But as Maciej said, evidence comes more and more every day. So we need to keep in mind that nothing is, everything is moving. And this is what Heraclitus said, the Greek philosopher. So everything is moving, but at least you can find concrete data on this ILEP recommendation paper in AMS.
Okay, Arrigo and Zeljko, any final words on these important question?
I would like just to say one sentence. That's like to say that we have to remember that we are prescribing nutraceutical. There's not counseling nutraceutical, because if we continue to think that they are compared with standard food and so on, we will never solve this problem. We have to remember that we prescribe them. This is a true prescription.
Okay. So we have two final comments, and we are at the end of this meeting today, I believe. From Amani again, that the add-on therapy is very useful for very high risk and statin intolerant, especially if they are genetically non-responders, I guess. One comment from my side, because I don't know if you agree with me that when I treat my patients with statins, I can really see that they are a group, I believe it is about 60%, that they are very good responders for statin therapy. About 20 to 25% or maybe 30%, they are moderate responders. But in fact, that they are very rare situation that they are not responders to statin therapy. So I guess there are no effect of statin therapy. In fact, in my clinical practice, but as I can see, taking into account the color of my hair and the beard, is a very long clinical practice. I don't remember non-responder, complete non-responder. I remember the situation that for 40 milligrams of rosuvastatin, it was about 7 to 10% reduction of LDL cholesterol only. So it was, let's say, very poor responder. But non-responder, I don't remember such situation in my clinical practice. But what is your? Have you had such situation that it was genetically non-responder for statin at all?
Very rare.
Oh, okay, yeah, Arrigo. Okay.
Very rare. It's closed.
I also think it's extremely rare, because when we are talking about real resistance to statins, it's extremely rare. But again, here we have also a phenomenon that I would also call pseudo-resistance. And when you analyze the situation, then you realize that a patient is non-adherent, for instance, or for some reasons, he or she is taking much lower dosage of statin than you have prescribed to her, and all other reasons. So if you are superficial, if you don't speak with thoroughly this issue and discuss this issue with patients, you might have an impression that the patient is, to a certain degree resistant, but fully resistance is very, very extremely rare. But even partial resistance is very often due to these reasons that I have mentioned. Most of the patients do respond. some of them, of course, to a full extent, some of them less.
Thank you very much, Zeljko, because in fact we have been now considering non-responders for PCSK9 inhibitors as well. Because for example, in our drug program, it is said that non-responders are defined are those with LDL cholesterol reduction less than 30% after PCSK9 inhibitors. And in fact, these are not such situation, and the most important situation is associated with the fact that these are not adherent, not responders, in fact, and those people usually do not take the doses of PCSK9 inhibitors, and that is why this is a very small effect. And the very last questions from Dragana Nikolic. Dragana, hello, hi. It is very nice that you are with us from Manfredi Rizzo Group. From Palermo, so another beautiful Italian physician. So thank you very much. You are with us, and I believe it is a question from Arrigo, because I remember our joint paper on the nutraceutical approach for cognitive function. Arrigo, remember, probably as far as I remember, in Archives of Medical Science it was published. So Arrigo,
yeah,
can you say a few words about the potential use of natural products in cognitive function improvement, whether it is an issue or whether it is not?
So I think that there is it is a very interesting field that we are to go in deep also as well, because there are many evidence that are really, really interesting. The most part of evidence are preclinical, but we have also some clinical trials that are showing something really important with some active principles, also from a safety point of view. And I think that is very, very relevant, because this is another field, like in nephrology, where we have not seen in the last year a great success in new molecules and new treatments. So probably everything that can slow the progression of a mild cognitive impairment to any kind of more serious dementia could be taken into strict account and to serious account, and we have to work on it. I'm really sure about that.
And I totally agree that cognitive function is probably one of the issues that we need to focus in next few years, not only as a complication after drugs, but as a condition itself. Okay, because I've talked so much during this evening, so I would like to say thank you, and I would like to give you voice to Niki, to Zeljko, and Arrigo for the final words, and to say goodbye to everyone, because I think it is enough for me. It was a great pleasure to be with you this evening. So Niki, the floor is yours as a first.
What I would like to give as a take-home message to all of us and all of the attendees is that we should remember is that the main problem is clinical inertia. So I believe that next time, for tomorrow, next day, next weeks, next months, every time we see a patient as doctors, we have to keep in mind that maybe this patient has already been taking some supplement. So it's really important to address the question, and it's very important to give the correct food supplements at the correct dosing. So please ask your patients what are they taking, because usually they are taking a lot that is crap. There is no evidence on that. More money, spent, and they don't take the really needed nutraceutical. So this is my main take-home message for our doctors.
Like,
well, I could only add to what Niki said. Do discuss with your patients whether they are taking any nutraceuticals and which nutraceuticals they are taking. Very often they don't think, since they think it is a natural product, that they have to tell you this. You ask your patient, what drugs are you taking? And he or she will tell you everything about antihypertensives, anti-clotting treatment, lipid-lowering treatment, but will not mention something that is very important. For instance, taking a food supplement or nutraceutical, which might first interact with some drugs that the patient is receiving, and having also some, on one side, positive side, additional effect that you are somehow thinking that is due to the drugs or dosage of the drugs that the patient is taking, but on the other side also having some interactions and adverse effects that you are not aware of where do they come from, because you have not asked your patient whether he or she is taking any food supplements, nutraceuticals, whatever preparation, other preparations. So do talk with your patients, do speak with your patients, and again, to the very beginning, to return to the very beginning. If we want to achieve our goal, we have to use every means that we have available. If these are nutraceuticals, and if the patient is reluctant to take statins, ezetimibe, whatever, do use adequate dosage and adequate nutraceuticals.
Thank you. And Arrigo, the final words.
Final words are we have to care about the fact that our patients don't do self-medication on nutraceuticals, and even self-confidence in buying any kind of products from internet. That is another big problem. And the second is that I totally agree that we have ourselves fight every day against our clinical inertia, but we have also fight against our cultural inertia, because I understand that at evening we are tired, but my main compliments are now for the people that is following us at this timing, because they are fighting very well against their cultural inertia, and I hope that we have given some positive message to them to take home this evening.
Okay, thank you very much, dear friends. It was a great pleasure and honor, and I do my best to meet very soon on another great, challengeable topic. So thank you very much. Have a good evening, and thank you very much for all participants of this webinar. Thank you. Bye-bye. Thank you.
Bye-bye.
Bye-bye.
Everyone.